please return to your seat.
네, 오늘 이 국제 심포지엄을 통해서 보건
Through this international symposium, we can learn from international and Korean experts discussing about healthcare improvement. We've done our group photo and let's go into the symposium. We will now begin with our first keynote speech delivered by strategic lead Nick Klasinga of OECD HCQO. We are connecting with him through Zoom real time. Let us try to connect.
Hello.
Good morning.
Good morning from Korea. Thank you for joining us today. If you could hear me well, could you please begin your keynote speech?
Thank you very much, and thank you for for inviting me. And let me start off by saying that it's a pity that I'm not able to join you in the room. I will do my best to to have this Zoom connection, but doing it live, I hope it's possible to have some interaction afterwards. So thank you for your kind introduction. My name is Nick Klasinga. I'm the strategic lead for healthcare quality and outcomes at the OECD in Paris. Actually, I had the pleasure of participating in HERA's international conferences already for several times. I think this is the fourth time that I contribute. But I want to congratulate HERA, also on behalf of the OECD, of not just hosting this conference, but all the achievements over the past 15 years in using data for quality of care. So the OECD recognizes that Korea is one of the important participants in the healthcare quality and outcome program. And I think together with all the participating countries and Korea, we have been learning a lot. So it's a real pleasure for me today to give a keynote to introduce the theme of strengthening of health data infrastructure in OECD countries to improve the quality of healthcare. And as was mentioned already very briefly in the introduction, there are several reasons why the use of real-world data, healthcare data, is important more than ever. In the introduction, the COVID crisis was mentioned. Of course, OECD countries wouldn't have been able to manage the COVID pandemic if not using more and more data that helps signal the developments of the infection and the relative effectiveness of intervention. So in that sense, the COVID-19 pandemic has been an accelerator of generating data and using them to manage a problem for the system as a whole. And in that sense, this acceleration is something that should now be capitalized upon and learned upon. But it's not just the use of data for managing a pandemic. Far from that. At the moment we see, especially in the transition phase after the pandemic, that data are extremely important to handle the various disruptions in healthcare systems. If there is a postponement of services and there are backlogs, having good data on the actual performance and having it in a timely manner is essential for helping to transition your system to a new phase of dealing with healthcare. So after the discussions on the pandemic, we are now with most of the member states of the OECD in discussions about how to handle the disruptions and with that the various backlogs that exist in their systems. Of course, that's also linked to the fiscal sustainability of healthcare systems. All OECD countries face the growing tension between the available resources and using them effectively. Also for that purpose, knowing information on healthcare outcomes and healthcare quality is key. Those data are essential for you to take rational decisions, to take the allocation decisions of resources in an informed manner, and do it with a long-term perspective rather than ad hoc reactions on shortages. And there is a fourth item which increasingly is coming up in the debates in the OECD, and that has to do with the environmental sustainability. That topic of the impact of the environment on health and the other way around, the contribution of healthcare to environmental issues, is also a topic which is getting higher and higher on the policy agenda of member states. And also for that, data and information is necessary to manage. And a very real problem, and during the last health committee meeting of the OECD in Paris, it became obvious, is that all countries are struggling with workforce shortages. So to optimize the use of the available workforce also means using available data, and especially data on quality and performance, as a way of managing workforce shortages. So a lot of reasons to strengthen the health data infrastructure. But of course, that's easily said or done. I listed here three key policy notions that are the kind of headings at the moment for discussions we have on strengthening data infrastructures. One is the discussion on the resilience of healthcare systems. And as you know, many member states have now captured the label of resilience as a way of increasing their responsiveness to not just the pandemic, but in a broader sense, the flexibility of the healthcare system and the opportunity to address healthcare services to the changing needs and the changing circumstances. Resilience of healthcare systems is built on good data on healthcare quality and performance. It can't do without it. Another development that you would see, especially in the European countries, is looking at the performance of a system as a whole and using health system performance assessment as a tool to assess the performance of the whole system. Health system performance assessment as a method was first developed by the World Health Organization, but in Europe, increasingly, health system performance assessment is promoted by the European Union as a way in which countries show how their system as a whole is performing, and quality of care is a key element of HSPA. And that all is linked to the notion that this is not just about data, this is about learning. This is about collecting data that are turned into information and that will help us to have learning healthcare systems. So to create learning healthcare systems, optimizing the use of healthcare data is essential. So three popular policy notions that are embedding the quest for strengthening data for quality of care, and that make this symposium of HERA today this very relevant. I'm not going to show you lots of different models on health system performance and quality of care. This is the model that the OECD is using when it's producing its health at a glance, the reports where we compare the performance of the various healthcare systems. But I just want you to be aware that quality is a key component of that. I will show you in a moment some of the examples of international benchmarking on quality of care, but in the reports of the OECD, quality of care is presented alongside access of care and cost of care and the health status of the population to really draw an overall picture of how a system is doing. So what data are used for measuring quality of care? As I said, I will focus my presentation on health system data and the type of data that the OECD presently is using for international comparative statistics. To start with, it is important that mortality data are used. So, for example, cancer survival data. So having a complete and functioning mortality data system is key. That's the most essential. But in addition, many countries have specific registries, clinical registries, and you have a representative of Denmark there. Denmark is one of the countries that has a long history of having clinical registries as one of the sources for data on quality of care. And key are administrative data. In combination with mortality or alone, but administrative data are the type of data that HERA for a long time has been collecting. The data that show you on the volume, but we know that also within administrative data, we can have a deeper look, like for example, 30-day survival data on chronic heart failure and stroke to understand what the system is doing. So mortality data, registry data, administrative data, medication prescribing data. I won't speak about that much today because your conference last year on the DUR project, the drug utilization review approach, was handling that, and I know other speakers will addressing this, but that's another source. And increasingly, in addition to these structured databases, there is data reported by patients and workers themselves. So we have the patient-reported outcomes, the prompts, and the patient's reported experiences. And we have increasingly data reported by healthcare workers themselves, for example, on safety culture. These are in the classical sources for quality data. And of course, we now see a movement where this is added by real-time data that come directly from electronic health records. I will address that later in my presentation, but I first want you to be aware of the basic developments of what kind of data are used for international comparisons. I will just give you some examples to show how these data are used. Here you see, for example, the 5-year net survival rate between 2010 and 2014 for melanoma. So basically, what you see here is a reflection of mortality data and cancer registry data, where we look at 5-year survival rates, and we follow in member states over time whether there is an improvement. And you see that, yeah, one could ask some questions about performance in Korea compared with other countries. But overall, having 5-year net survival rates and the trend in there is an important source of information. Of course, one can go one step deeper in the cancer registries and not just look at the 5-year survival rate. So how good is the system in keeping people who are diagnosed alive for a longer period, but also at the cancer stage at the moment of diagnosis. This, for example, proved to be quite relevant in the COVID period. Many countries were curious to know how are our cancer services doing, how are our screening programs doing, and one of the ways of finding that out is to see of what is the severity of the cancer the moment it's diagnosed. And here again, making international comparative data and having trends about how the situation is in your own country can help you to improve things. My own country, the Netherlands, we learned that in 2020, the stage of diagnosis was getting more severe during the COVID. And luckily in 2021, it was back to the levels that we measured in 2019. But it was important information for the policy-making process and for the decision-making of which screening programs and activities should be restarted after several periods of postponement. Another way of dealing with mortality data and admission data is the 30-day mortality after admission for acute myocardial infarction based on linked data and claims data. This again is an area where where HERA has been participating very actively over the years. But you see here that basically what the OECD tries to measure is the overall shift in 30-day case fatality rates. Overall, we see that in almost all countries there is an improvement, and of course we try to monitor whether this improvement is continuing. And the small white boxes are data for 2020. Those were the countries where that in a very early stage could signal whether COVID had an impact on the 30-day case fatality rate. Another, if we take that one step further and we link the administrative data on hospital admission and readmission with the mortality data, then you see here the data that are published on patient outcomes within 1 year of discharge after ischemic stroke and congestive heart failure based on mortality and administrative data. The OECD is doing this with a large group of countries to basically see how the cohorts of people who have been admitted for ischemic stroke or congestive heart failure are faring over time. So you combine readmission with the mortality, and the real challenging element at the moment is not only having these two linkages, but also linking this to prescribing data. So we hope in the near future to also show this information in combination with what we know about the compliance with medication, especially for people with congestive heart failure. Also in administrative data is the now, I think, 12 years data collection on patient safety indicators. This, of course, depends on a quite detailed coding system in your data system. But here we see the data that are collected on adverse events in hip and knee surgeries as reflected in post-operative pulmonary embolism or deep venous thrombosis. Again, I'm not going into all the details, just to show that a lot of countries are collecting these clinical data as safety information, as information on safety in their hospital systems, and to reflect on the performance. Here we shift from using the administrative databases to look at the clinical care in hospitals to looking in what is happening in primary care. So a very popular one here is avoidable hospital admission, and basically seeing for chronic conditions like COPD in this example on whether the health system is able to keep people with COPD, but also chronic heart failure and diabetes out of the hospital. So basically whether you see a trend in decline of this as a reason for admission in the hospital systems. Here again, you also see the data from Korea included. You see the improvement that have been made between 2009 and 2019, basically going from the white circle to the purple circle. But you also see several countries already using this data on 2020 to really learn them whether COVID had an impact on primary care in that respect, that people with chronic conditions were more admitted to hospitals with complications. So it tells you something about whether your primary healthcare system was resilient enough to deal with the challenges of a major pandemic. Some examples of patient-reported outcome measures. Here you see some of the data that the OECD with groups of member states has been collecting on hip and knee operations. This is on knee operations, and basically in these cohorts, groups of patients are asked before and after the operation on very standardized things like whether there was a difference in pain and whether there was a difference in mobility. Of course, these are not national representative data. These are groups of centers in countries that are systematically already collecting these data, but it's an area that has been developed very much over the past 4 years. mainly on the request of a ministerial conference where the Ministers of Health asked the OECD to promote these patient-reported in the indicators. Here you see similar patient-reported measures in the area of breast cancer. These are the breast Q measurements, which have now been ongoing for, I think, about 6 years, where in groups of countries and groups of hospitals, before and after different types of operation, we try to assess the satisfaction of women with the cosmetic results of the operation. Here you see the differences. You also see that what we learn in these discussions is the types of interventions that are there. And one of the things we learned, for example, is that during COVID in several countries, including the UK, the more complex types of operations were actually put on hold. In a way, working with groups of hospitals, collecting this data helps to get an image of the international comparison of patient-reported outcomes. Same can be done with patient-reported experience measures. This is the survey from the surveys that the OECD is promoting, and Korea is participating in this one, where we ask patients about their experiences, like, did the doctor spend enough time with you during your last consultation? And you see over time the difference. And here, in addition to this general information, also in the area of patient safety, several countries are collecting systematic information of safety events as experienced and reported by patients themselves. So patient reporting that they experienced a medication-related mistake in 2020. And last but not least, as I said, information can come from the healthcare workers. And this is the work that in the past 4 years has been pushed forward, where the OECD has tried to support countries in standardizing internationally the measurement of health worker reported safety culture. And actually, here also we learned, especially in the data from the US, that there was a big shift in safety culture during the pandemic. It became worse. And the most recent measurements also see that, at least in the data in the US, that hasn't been picked up to the old levels yet. So this is just a series of examples of the type of international comparative data collections that are ongoing. When I focus on a country itself, speaking about the data means that you really start to take stock of the different types of data that you have in an information system. And those are your data you have in the public health sphere, your classical healthcare data in the different sectors, hospital, primary, emergency, medicine, the long-term care data, and that's increasingly an area where the OECD works with countries, so the nursing homes, but also home care and allied health care, and the link with social care data, so support for living at home, transport services, and the home situation. More and more countries are trying to build bridges between these different silos of data, enhancing the linkage capability, and then putting that in a contextual setting of the social situation, employment situation of people, economic situation, income situation, and environmental information. So having a whole system approach is important. So that brings me to the final part of my presentation, where I show you some of the initiatives of the OECD over the years to work on health data governance. And you see that the present debate on the big data is actually building on work that already started in 2010, when the health ministers asked the OECD to look at a more effective way of using electronic data. I'm not going to in all these reports, just to tell you that the essence has been of looking at the maximization of the possibility of electronic health records and the use of linkage of data. And in the past years, a lot of emphasis has been on the actual governance. In 2017, there has been an OECD Council recommendation on health data governance. And in the past years, the OECD has been evaluating the implementation of this governance. And last year, 2 reports were released on countries, one on the Netherlands, but then also on another one on South Korea, and later today my colleague Lux Lagromirsky from the OECD will present the findings of that in-depth study on Korea. So just to give you some ideas what type of information the OECD collects. First, we start by looking at the data set availability. And you see here, basically we looked at 8 key elements of data sets availability, their maturity and use in survey work. And you see that that's together with Sweden and Denmark, Korea ranks quite highly on the availability of data. When we try to assess the percentage of key national health data sets availability and regularly linked for monitoring and research, we see a slightly different picture. We see then here you see bars about the percentage of key national data sets available, but also percentage of available data sets regularly linked for research, statistics, and or monitoring. And you see here that Korea is in a good position, but that is surely an element that can be should be able to be improved when compared with other member states. Here you see the same information reflected in a table, and I think you selected rightly to have Denmark as one of the countries to reflect upon today. When we look at national health data governance, and we look at the 15 governance elements that the OECD and its council recommendation is promoting, we see that Korea also scores quite well on that, but it also today, when you speak with the UK, you will learn that there are elements that could be strengthened. So, in a nutshell, from an OECD perspective, I like to see to the whole movement of the shift from data to information during and after the pandemic. I see that a lot of emphasis has been put on mortality statistics and calculations on excess mortality and the standardization. Registry data used for the moment of diagnosis and work in the orthopedic registries. Administrative data for capacity planning, ICU, hospital planning, and especially much more timely information to help to address the shortages and optimal use of the available capacity. The electronic health records to really help to get a timely exchange of patient data between the providers for integrated care, digital and virtual care, which was introduced, and setup of new patient portals and real database research using data models, and an increase in use of survey data. So briefly, one of the countries that has thought to set up a national strategy for data infrastructure is Canada. I took this from their report, and here you see what they also want to go to a learning health system, but they see that this is not just about the technicalities, but this is also about the governance, the trust, and the other softer elements that need to be in place to have an optimization of the use in health data for quality of care. So if we do a root cause analysis at the moment, I would say to Korea, well, if you want to look at national strategies for data infrastructure, have a look at New Zealand. When you want to learn from governance models with a strong role for government and a national agency to steer the process, have a look at the US, UK, Denmark, and the Netherlands. When you want to look at the policies and regulation with respect to national standards, interoperability, vendor market organization, secondary data use, and there's a whole set of countries, and you will hear later today where you can refer to. I put here France, but also the initiatives with the European Health Data Space that the European Union is presently promoting. And I know Korea has a similar initiative ongoing. And if you want to have the discussion about trust, data literacy, and inclusiveness, examples from Finland and the Netherlands and the debates that are going on there could be of use. So to conclude, national governments are able to improve performance, and they try to optimize the use of data. And measuring quality of care in terms of effectiveness, efficiency, and equity is important. It's a key thing for the sustainability, just financial and environmental, and for resilience. It's necessary when you want to increase your capacity to monitor and optimize healthcare services and want to steer on quality of care, and if you really want to operationalize the idea of a learning health system. As I said, a report has been released on the request of the Korean government on an integrated health information infrastructure. So please have a look at the report, and my colleague Luke Slavomilsky later today will address some key findings there. To conclude, in Korea, I would say there is a big basis already of good data systems and initiatives that can potentially be used, but the real challenge seems to be in turning data into information and make information fit for purpose and use, really to tailor the information for the various decision-making choices that you have in your health system. It asks for leadership, and there again, I want to applaud the work of HERA that it has been doing over the past 15 years. It asks for prioritizing focus on system-wide agreed topics like quality and strengthening the learning components, just seeing who is actually using the data and can I have a cascading in my system between national and international benchmarking and internal learning. Thank you very much, and looking forward for the